Hi, everyone. This is Melinda Caughill with I-65. Let's see if I can actually say hello. Look, there I am. Hi, everybody. There's so many names of people in this list that I recognize. So hello to everyone. I've kind of chatted a little bit with some people who came on early enough that I saw. But anyways, I digress. All right. Today we are here to talk about, yes, you can help your clients with Medicare and help them avoid permanent and costly Medicare mistakes. If you haven't done so already, I have a poll open. Please feel free to participate by answering those 2 quick questions. Also, just a little bit of housekeeping. If you need CFP credits, I will need your middle name, your CFP ID, and the last 4 digits of your Social Security number. So if you did not put those in when you registered for the webinar, I will be reaching out to you in order to get those CEs processed. If you need SHRM credit, I will be sending out an email afterwards with the code of the actual SHRM credit. Now, as we're going along, if you have any questions, there is also a Q&A panel. Feel free to type your question into the Q&A panel. I will try to do Q&As before the end of the session today. We are recording, and I will also put together a link for the recording afterwards. Okay. So with that, yes, you can help your clients avoid Medicare enrollment mistakes. Let's kick it off. So who the heck am I? If you don't know me, I am the co-founder of 65 Incorporated and I-65. I'm a Medicare expert, and I have been educating now clients with Medicare for almost a decade. I do a lot of presentations around the country, and a lot of the bridge metaphor and things that you're about to see are basically my personal creation. Yay. Anyways, so that's me. But let's move on to the important stuff. So Medicare today. Let's start by introducing you to what the Medicare landscape is actually like in this country. I don't know, I'm assuming most of you know this, but we have 3.6 million people turning 65 each year in this country. Unfortunately, most of those will tell you, I don't understand Medicare. So as they go through the Medicare enrollment process, it's very likely they'll encounter Medicare mistakes. Unfortunately, just one mistake can literally cost a person thousands of dollars a year for the rest of their lives and even keep them from getting needed healthcare services. We tried to put our arms around how big is the Medicare enrollment mistakes problem in this country. So what we did is at 65 Incorporated, we deal with consulting clients. So we created an average consumer experience and then extrapolated that number out to the national population. In this way, we've estimated seniors make about $6.4 billion worth of Medicare enrollment mistakes annually. And now I can almost hear some people's thoughts, like, really? Yes, really. So let me walk you through some of the case studies that actually make up this statistic. So let's start with John. Remember, these are actually real clients. Of course, those aren't their real photos and probably not their real names, but they are real experiences of our clients. When John turned 65, he was still working. He went into his employer's HR department and basically said, hey guys, I'm turning 65. What do I need to do about Medicare? They said, nothing, John. You're still employed. You're still enrolled in the health plan. You're good. So John took no action related to Medicare, which was unfortunate because John worked for a small employer, less than 20 employees. As a result, by not taking action to enroll in Medicare, John has no primary payer for Medicare now. No primary payer for health bills, and will likely have to pay for all of his medical care since turning 65 out of pocket. So what is that? Well, it depends on John's health. What kind of services has he needed since turning 65? 500, 5,000, 50,000? Depends. David and Sandy. When Sandy turned 65, her Medicare card arrived in the mail automatically. When David turned 65, 6 months later, he waited for his Medicare card to arrive in the mail as well. But it didn't come, and it didn't come, and it didn't come. Finally, David took action several months later. That's when he found out the difference between him and his wife's situation. Sandy was already enrolled in Social Security benefits, so Medicare enrollment was automatic. David had to take action to enroll in Medicare because he was not yet receiving Social Security benefits. So now David is looking at a severe delay in Medicare coverage. He cannot enroll in Medicare until January during the general enrollment period, and then Medicare coverage will not begin until July. He's going to pay a late enrollment penalty for the rest of his life, too. And late enrollment penalties when it comes to Medicare are not like a parking ticket where you pay it once and it goes away. That's not how it works. So until then, what is David going to do for health care coverage? I don't know. So that's kind of a bummer. All right, one more for you that I will subject you to. So this is Jane. When Jane was 67, she was still working for a large employer. The employer came in and said, "I'm so sorry, Jane, we have to let you go." So Jane went on the company's COBRA coverage. To Jane, this was the same type of coverage she had always had, just more expensive. So she took no action related to Medicare, which was unfortunate, again, because as soon as Medicare coverage is as soon as employer-related coverage is no longer related to active employment, Medicare treats it differently. She should have taken action to enroll in Medicare Parts A and B in order to have a primary payer, but she didn't do that. So Jane, 10 months later, something happened. She got a cancer diagnosis, and a pretty serious one. At that point, she realized her mistake. She should have enrolled in Part A and B, but she didn't. Now she doesn't have a primary payer. She no longer qualifies for a special enrollment period. She has to wait until January for the general enrollment period. Medicare coverage will not begin until July. So in the meantime, what does she do for these cancer treatments? She's on the hook as the primary payer. These are the kind of things that can kind of happen when you make Medicare mistakes. So when you start seeing like $10,000 a month for 10 months, 11 months, now you can start to see why that $6.4 billion number actually exists. Okay, so this isn't good, right? But why is it happening? Well, quite frankly, the reason it's happening is because we are literally forcing seniors to become Medicare experts simply to enroll in the program. In fact, whenever a person is about to turn 65, they will automatically get a booklet in the mail explaining Medicare. Maybe you've seen it. It's called Medicare and You. Here's the thing. The 2020 version of this guide is 120 pages in length. Yeah, so if the client decides, well, that's not really for me, what else could they potentially do? How about Social Security? Head to the Social Security Administration, right? After all, they're in charge of Medicare enrollments, premiums, penalties, and more. But Social Security by itself has over 2,700 rules and thousands of codicils. But regardless of whether you want to talk about Medicare or Social Security, there's only one phone number you call. You get who's ever up next, regardless of what they know and often don't know about Medicare. So if Social Security isn't working for your client, Medicare and You booklet's not working for your client, where are they supposed to turn for help? That's why they're making it up. They're turning to professionals that they feel they can trust in hopes that you'll provide some sort of Medicare enrollment guidance. Human resources professionals, trade professionals, medical professionals, and one of the very first places that they often turn to is a financial professional of some sort. Unfortunately, today, still, most of the professionals that they're turning to for help still aren't helping. which means if you are willing to engage in a Medicare conversation with your clients, the employees, the people that you work with, this is a huge opportunity for you. You get to become your client's Medicare enrollment hero, literally donning a superhero cape. Yay! There are so many business benefits to becoming a client's Medicare enrollment hero. You are providing an immense amount of value and peace of mind to your client, which does turn into increased client leads and referrals. You can easily differentiate yourself from the competition. You get a foot in the door with prospects who might not otherwise talk to you. You can literally prove to clients how you're saving them thousands in mistakes. But arguably, having a Medicare conversation with your clients, there's one even more powerful reason to do so. You have a literally guaranteed conversation starter for more difficult topics. Estate planning, long-term care planning, healthcare directives, end-of-life planning. These are all topics that, let's be honest, they're not exactly fun topics. As a result, people have a tendency to deal with them later or put that off, or, that's too depressing to think about right now. I call these the la, 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 I'm not listening conversations. But the power of Medicare is there's literally a deadline on the calendar. Regardless of how you feel about Medicare, depressing or not, as soon as a person's about to turn 65, they have to deal with the Medicare conversation. If you are having a Medicare conversation with your clients, you can easily transition the topic to long-term care planning, healthcare directives, estate planning, retirement income planning, whatever you need to discuss, literally, it can come out of the Medicare conversation. So that's one of my favorite reasons to engage in a Medicare conversation with clients. Okay, how do I get started by helping the clients with Medicare? Well, you start by learning the steps of Medicare enrollment. Most people today believe Medicare enrollment is a 3-step process. Step 1, choose your plans. This is where you choose United Healthcare, Humana, Aetna, Blue Cross Blue Shield. Then you enroll in Medicare. Step 2 is enrolling in Parts A and B. And when you get your Medicare card in the mail, then you can actually enroll in those specific plans you initially chose: Part D drug plans, supplements, Advantage plans. In fact, even Medicare.gov will tell you that Medicare enrollment is a 3-step process. Please, pretty please, don't believe it. Medicare enrollment is actually a 6-step process, and here are the 3 steps that people typically miss. So I'm going to take you through all 6 steps of the Medicare enrollment process. So let's start at the real step 1. Again, this is not picking plans. It is actually determining your timing. We call it check your timing. What we mean by this is, now at age 65, the best time for you to enroll, or should you be delaying Medicare enrollment? Heaven forbid clients delay when they should enroll, or they enroll when they should delay. Both can end up in very permanent, very costly Medicare mistakes. In fact, all 3 of the case studies I told you about in the beginning, all 3 of those were timing mistakes. So step 2, once you know the timing is right for you, step 2 is choosing your Medicare path. And by path, we mean type of coverage. Is it original Medicare with a supplement, also known as a Medigap? Is it a Medicare Advantage plan, retiree coverage, military coverage, federal employee health benefits? What is the best for your client's unique needs? It's really important that they take the time to look at the options that they have and choose what's best for them. Once you know the timing and the type, then you can go ahead and choose specific plans. So step 3 is where you pick United Healthcare, Humana, Aetna, Blue Cross Blue Shield. Please do not hurry this step. Wait until step 3 to actually pick specific plans. Okay, then you get enrolled in Medicare, Parts A and B through the Social Security Administration. When you get your Medicare card in the mail, you can officially sign up for Part D drug plans, Medicare Advantage plans, supplements. Then last, but definitely not least, please review your coverage annually. Step 6 is open enrollment review. Each year, plans change. Medicare Advantage plans, Part D prescription drug plans change how they work, premiums, deductibles, out-of-pocket costs, the medications they cover, pharmacies in network. If you are not watching how your coverage will change in the coming year, you're the one left paying the bill. And we have literally seen that bill be thousands, tens of thousands, even hundreds of thousands of dollars of difference. Our company's record holder is a person who saved $235,000 by changing drug plans for just one calendar year. I have a quick question. What was step 5 again? Step 5 is the administrative step where you actually sign up for Part D drug plans, supplements, and Advantage plans. You can't sign up for those plans until after you've officially enrolled in Medicare. So that's why it's sort of an administrative step. Step 5 is signing up for those extras insurances. All right, so now we know all 6 steps. Most tools and resources that are available today are really helping people with steps 3 through 6 of the Medicare enrollment process. In fact, most insurance agents, just about all the insurance agents' plan selection tools, the Medicare.gov Plan Finder tool, all focused on steps 3 through 6. But what about timing and type? If we're being really honest, there are a few things out there other than self-study that are really helping people with these steps, which is scary because it's actually in these 2 steps where most of the permanent and very costly Medicare mistakes are made. But luckily, you're here. Today, we're going to focus really on the first 2 steps to help you help your clients avoid the most common and costly Medicare mistakes. Okay, so let's dig into the first 2 steps. Okay, so timing Medicare enrollment. This was step 1. Is it best for you to enroll in Medicare at age 65, or should you be delaying Medicare enrollment? Because again, heaven forbid you delay when you should enroll, or you enroll when you should delay. There are several factors that can impact this timing decision. Social Security benefits, are you receiving them or not receiving them? The type and the quality of the existing health coverage that the client has. Employer size, employment status, are you employed actively or not employed actively? HSA status, are you actually making contributions to a health savings account? There's a few more, but these are the main ones that we're going to go over today. All right, so Social Security benefits status. If the client is receiving Social Security benefits, they will be enrolled in Medicare automatically. If not, that client has to take action to enroll in Medicare. Remember the David and Sandy case study. If a client is receiving Social Security benefits, you are required by law to keep Part A at a minimum. If you do not maintain at least Medicare Part A, you will have to potentially pay back benefits and stop receiving them in general. So, condition of receiving Social Security benefits is Medicare enrollment. Part B medical insurance, though, that can potentially be optional. So do you have to keep it? Should you enroll in it? If not, if it's in your best interest not to keep Part B, you have to take action to suspend it if the client is receiving Social Security benefits. The type and the quality of the health coverage also impacts whether or not a person should enroll in Medicare. Do they even have existing health coverage? If so, will that type of coverage be primary or secondary to Medicare? Primary payer means that that plan will pay the first amount of whatever it owes to the bills first. Primary payer pays first. The healthcare provider then sends whatever amount is remaining of those bills to the secondary payer. Depending on the coverage, Part A and Part B enrollment may be preferred or necessary because Um, there are primary and secondary rules in Medicare. Some health coverage is considered the primary payer. Some health coverage is considered secondary. So it's really key to get to know what type of health coverage you have and will it be the primary or secondary payer. All right, employer size. We're going to talk about a small employer first. This is defined as a company with fewer than 20 employees. Please know that a company with fewer than 20 employees can opt to exclude those who are turning 65 from the coverage. So they can say, I'm sorry, Don, you turned 65, we just don't cover you anymore. So you have to go on Medicare fully. So Medicare would be the only payer for companies who opt to exclude those 65 and older from coverage. If a Medicare eligible individual can continue on the coverage, the plan becomes secondary to Medicare. So remember, John, a small employer plan is secondary to Medicare. So a person has to enroll in Part A and Part B if working for a small employer. Okay, a large employer. This is defined as a company with 20 or more employees. Now, in this case, the company has to provide the same benefits to all employees regardless of age. They cannot change premiums, costs, coverage for Medicare eligible individuals or dependents. They also cannot offer you incentives to drop the employer coverage and enroll in Medicare. That is not allowed either. Part A enrollment. Okay, there is a myth in this country that as soon as you turn 65, you have to enroll in Part A. Nope, that's not true. It's often recommended, but not required. It is only required when you are receiving Social Security benefits. If you are not receiving Social Security benefits, Part A is technically optional. Now, Part B enrollment, this is also optional and almost always not recommended. So we can get into that a little bit later about why it's not recommended related to guaranteed issue right. A company with 20 or more employees, please note, late enrollment penalties will not apply if employer coverage has been continuous and the drug coverage considered creditable. So people get very fearful of, well, I'm delaying coverage, but will I face these late enrollment penalties? As long as you have been covered continuously with no gaps in coverage of 8 months or more, late enrollment penalties will not apply. You will qualify for a special enrollment period. This is a period of time that you get to trigger the start of in which to enroll for Medicare. Okay, I'm going to talk about a case study of a woman who enrolled in Medicare too soon. Carol became fearful of late enrollment penalties when she was about to turn 65. So she went ahead and enrolled fully in Medicare, Medicare Part A, Part B, Part D. But she also kept her husband's large employer group health coverage, which essentially meant that Carol enrolled in Medicare Part B and D too soon. Both of these parts were parts she was paying for, but really could not ever benefit from. So over the next 20 months, she basically threw away $5,200 on coverage she couldn't use. And now, because she's been enrolled in Part B for more than 6 months, she no longer has a guaranteed issue right to get a Medigap policy. Carol has two pre-existing chronic medical conditions. The likelihood of her getting a Medigap policy with these two medical conditions is slim to none. So please, enrolling too soon or too late can be bad. All right, employment status. This is also a factor of enrolling or delaying. Coverage not related to current employment. This is what we're going to be talking about. So COBRA, retiree coverage, severance packages, all of these are coverages that a person can have, but it is no longer related to somebody actively employed. This could even be, this is what trips people up. the employer doesn't call it a retiree plan. The employer still calls it the exact same coverage you used to have when you were still employed, but you are not employed. Medicare will treat it differently. This coverage, not through active employment, becomes secondary to Medicare. Part A and Part B enrollment is a must. Without Medicare, there is no primary payer when coverage is no longer related to active employment. Okay, last but not least, health savings accounts. So once enrolled in any part of Medicare, Part A, Part B, Part A, Part B, whatever, an individual is no longer eligible to make contributions to an HSA. They can start taking out HSA funds to pay for different expenses, but they can no longer make contributions into the accounts. Those who keep a high deductible health plan with an HSA should consider strongly putting off Social Security and potentially Medicare in general if they want to continue making contributions to an HSA. Once enrolled in any part of Medicare, funds can be used again to pay for Medicare expenses except Medigap premiums. So let's do a case study real quick. This is Maria. Maria thought, like a lot of people, that when she turned 65, she had to enroll in Medicare Part A. So she did, but she did not stop making contributions to her HSA plan. Maria's HSA contributions now have to be pulled out, withdrawn at a 6% penalty, and she has to repay her employer for the contributions that they made to her HSA while she was enrolled in Medicare Part A. So, is it a huge consequence? No, but it is by no means something people want to find out as a surprise. All right, so that was all conditions that can dictate whether or not a person should enroll or delay. Let's talk really quickly about the most common enrollment periods for Medicare. I'm going to address 3. There's actually like 50 enrollment periods, but for most people, 3. Initial enrollment period, special enrollment period, and general enrollment period. Number 1. And the initial enrollment period. This is the 7-month period surrounding a person's birth month. So if your client was born, for example, in January, their initial enrollment period would begin in October and go through April. Now, there is one caveat. If your client's birthday is on the 1st of the month, we have to shift it. So let's say your client was born January 1st. Their initial enrollment period now begins in September and goes through March. Why? Because it's Medicare. All right, so that's the initial enrollment period. Special enrollment period. This is a period of 8 months that allows a person to enroll in Part B without penalty or delay, or Part A as well. But typically the reason somebody's triggering a special enrollment period is typically for Part B. You must qualify for this period. It is not necessarily a given for everybody. To qualify for this period, since the age of 65, that person must have had an employer coverage-based plan, an employer-provided plan based upon current employment or that of a spouse without any gaps of coverage of 8 months or longer. That's how you qualify for a special enrollment period, and then you can actually enroll in Medicare without penalty or delay. Now, if you don't qualify for a special enrollment period, then we're looking at the general enrollment period. This is a period for those who missed their initial enrollment period or do not qualify for a special enrollment period. This occurs each January 1st through March 31st. When you have to use the general enrollment period to enroll in Medicare, Medicare coverage will not actually begin until July 1st. So be aware of coverage delays if you have to use the general enrollment period. So with that in mind, then we're going to transition to late enrollment penalties. Often people who have to use the general enrollment period can face late enrollment penalties. The Part B penalty permanently increases the amount that a person pays for Part B by 10% for each 12-month period that they were not enrolled in Medicare, that they should have been enrolled in Medicare. So let's take a look at the actual cost calculation. So today, in 2020, the standard Part B premium is $144.60. So 10% of that is $14.46. If your client delayed Medicare for 3 full years, 36 months, the penalty that would get added to their Part B premium each month for the rest of their life would be about $43.38. Again, this amount, though, changes as the Part B premium changes each year. So, and again, follows a person for life. Part D penalty. The Part D penalty permanently increases the monthly premium of a person's Part D drug plan by 1% of the standard Part D drug plan for each month without creditable drug coverage. So months delayed. So let's say our client delayed Part D enrollment for 48 months. In 2020, the standard Part D drug plan premium is $32.74. So you're looking at basically 32 cents, 32.7 cents for each month delayed. So you're looking at a penalty then of $15.72 for that penalty added to the Part D premium for each month for the rest of the person's life. So, okay, remember, please, late enrollment penalties follow a person for life. It is not a parking ticket where you pay it once and you're done. So, all right. Let's transition now to step 2. So that was step 1. And by the way, I will address questions at the end. So I see some questions coming in. I do see them, and I will get to them the best that I can. So step 2 is choosing your Medicare path. Which type of coverage is best for your client's unique needs? Is it original Medicare with a Medigap policy? Is it Medicare Advantage, retiree coverage, military coverage, federal employee health benefits, some other sort of coverage? Now, in order for me to help you understand why this step is so important, I'm going to take you through how the Medicare landscape actually is structured. You've probably heard that Medicare has 4 parts, A, B, C, and D. It's a very common way that Medicare is being taught. But of course, we don't teach it like this. And the reason why is because we have seen way too many clients treat this like a shopping list. I have to get an A, a B, a C, and a D. No, 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 no. C is technically just a different way to get Medicare Part A, Part B, and Part D. So instead, we prefer to teach Medicare has 3 basic parts and then 2 distinct paths, 2 unique ways to get those 3 basic parts of Medicare. So let's talk about what the 3 parts are first and then the 2 paths. Part A, this is hospital insurance. This is the coverage that a person will have for inpatient care in hospitals, skilled nursing facilities, home health care. Please note, when I say home health care, I do not mean activities of daily living. So if you have a home health aide coming in to help a loved one with eating, bathing, transferring, getting dressed, that is not what is covered under Medicare Part A. Home health care services that are covered are skilled services, services that are provided requiring the skills of a nurse or a physical therapist or an occupational therapist. So, and hospice, this is also covered under Medicare Part A. Medicare Part B, this is medical insurance. This is the type of insurance that a person needs to diagnose and then treat medical conditions. Doctor's visits, specialist visits, labs, x-rays, diagnostic services, and preventative services are also included under Medicare Part B. Technically, this is considered optional coverage, but I kind of laugh because if you don't get it when you're supposed to get it, again, you can face late enrollment penalties. So that's Part B. And then Part D, D for drugs. This is the prescription drug coverage under Medicare. These plans are provided by private insurance companies. You will not get a federally provided government Part D drug plan. All of the plans are provided by private insurance companies. They help to cover the cost of prescription medications. They almost never fully outright cover the cost of prescription medications. Again, this is considered optional coverage, but if you don't get it when you're supposed to and you need to enroll later on, late enrollment penalties. Okay, so now let's talk about the two distinct paths of Medicare that most people face when they're about to turn 65. These are the two paths that they go down in order to receive those three basic parts of Medicare. Let's talk about original first. This is Medicare administered by the U.S. government. So we put the Capitol building in the background. When you choose to head down this path, you can see any provider who accepts Medicare. There are no traditional networks. When you visit a doctor, you pull out your Medicare card. That's how you are identified. Now, all paths of Medicare do require a person to enroll in Part A and Part B. But on the path of original Medicare, you could stop right here and say, I'm done. I'm enrolled in Medicare. Yay. No, boo. Because A and B by themselves can become very expensive. Part A has a $1,400 hospitalization deductible. Hospitalization, not annual. Part B, 20% of all healthcare bills are your responsibility coming out of your pocket. And A and B by themselves have no spending limit. So you can spend and spend and spend until you basically have nothing left. So for comprehensive coverage when you choose the path of original Medicare, you also add a Medigap policy. A Medigap and a supplement are the same thing, and a Part D prescription drug plan. When you put these two pieces into place, most, if not all, of the out-of-pocket costs of having A and B by itself can poof, go away. Okay, so let's take a look a little bit more at what a Medigap policy is. Again, this is also called a Medicare supplement. Medicare supplement and Medigap policy are the same thing. Medicare supplement policies, Medigaps, help to provide coverage of the payment gaps in Medicare Part A and Part B, the deductibles, the copays, the coinsurances. For this coverage, you will pay a monthly premium and then have few, if any, out-of-pocket costs. For most states, the federal government has standardized Medigap plans into plans known by letters, plans A through N. For many years, one of the most common plans was a plan known as Plan F. Plan F is now no longer able to be sold for people newly qualifying for Medicare. So now the most commonly known plan defaults to Plan G. States like Wisconsin, Minnesota, and Wisconsin, Minnesota, Massachusetts. I'm from Wisconsin. Got to say it multiple times. These states use their own standardization. These states standardized Medigap policies before the federal government took action to do so. As a result, their standardizations have been grandfathered. A guaranteed issue right ensures that you can get this coverage without going through underwriting. Let's take a look really quickly at sort of the Medigap policy coverage chart. So I'm not going to go into this in detail, but please note again, the biggest difference in 2020 is that Plan C and Plan F can no longer be sold to people newly eligible for Medicare. People who have been eligible for Medicare can still get these plans, but be very cautious when looking at getting a Plan F or a Plan C because there's really no new blood going into these plans. So, all right, what is a guaranteed issue right? This right ensures that you can get a Medigap policy without going through medical underwriting. This means insurance companies cannot deny you a Medigap policy or raise your premiums based on your medical history. You have this right for the first 6 months that you are enrolled in Medicare Part B. But after that 6-month period, you may not be able to get a Medigap policy because insurance companies can ask you about your health. Some states, New York, Connecticut, Massachusetts, and Maine, do provide extra guarantees for guaranteed issue rights. So you have that issue right for a lot longer than in other states. And other states do have additional rules, but for the most part, New York, Connecticut, Massachusetts, and Maine are the only ones with continuous guaranteed issue rights. So let me break it down. The path of original Medicare, you pay a monthly premium, and then you have no out-of-pocket costs for healthcare services. This is sort of an example of the average costs that you can expect to pay. Part A and Part B are grayed out, and the reason they are grayed is because regardless of path, again, you are subject to any costs for Part A and Part B by itself. So those aren't a part of the comparison factors when we're looking at different paths. You pay it regardless. Medigap policies, depending on where you live and the type of plan that you're getting, can range from $100 to over $300. Typically about $183. That's the national average. Part D plans range from $50 to over $100. Again, the standard average premium is about $32 in 2020. But once you've paid those monthly premiums, you basically have no out-of-pocket costs for healthcare services, typically once you've paid the Part B deductible. All right, so that is the path of original Medicare. And now let's talk about the path of Medicare Advantage. This is a path that people get very excited about today. Lots of marketing going on about this path. This is Medicare administered by a private insurance company, so we put a corporate building in the background. When you choose this path, the insurance company is in charge. They get to make the rules. When you visit a doctor, you pull out your insurance card. That's how you are identified. Again, Medicare Advantage policies will require that you enroll in Part A and Part B, but they are going to change the rules that you have to follow in order to get those services. These plans will usually roll in Part D drug coverage as well. And then here come the exciting parts. These plans usually have very low or no monthly premiums. Big deal. And extra benefits, free vision, free hearing, free dental coverage, free gym membership that typically the path of original Medicare does not include. So they'll take all of these things, mix them together into a type of coverage you get on this path known as an MAPD plan, Medicare Advantage with Part D drug coverage. This is what Medicare labels Part C, but it's really not a part. It is a part of a path. So this is a path. This is a way to get the parts of Medicare. Okay, here are the rules that you have to follow when you choose to head down this path. You have to see providers in a network. If you go outside of the network, that bill may be completely yours to pay, and legally, networks can change at any time. You're subject to prior authorization rules when you head down this path, meaning the doctor may say, oh my gosh, Melinda, look at that knee. That looks horrible. You're going to need knee surgery. But hold on, before I schedule that knee surgery, somebody has to get on the phone with the insurance company and get their permission. If we don't get permission for that service, I'm on the hook paying for it. So prior authorization rules are becoming a much, much bigger and much more common thing in Medicare Advantage plans as time goes on. More and more services are falling under the prior authorization umbrella. And of course, you are subject to paying any deductibles, copays, and coinsurances whenever you use healthcare services up to that plan's out-of-pocket spending limit. Okay, so let's break this all down. So on this path, you are going to pay no monthly premiums, but then you're going to pay every time you use healthcare services. And if you don't follow the rules of the insurance company, you can be responsible for paying the full cost of any healthcare service. So let's take a look at this path's cost chart. So again, Part A and Part B are grayed out. You're going to pay those regardless of which path you choose. MAPD plan premiums often are zero. There are very commonly zero premium plans available in most areas throughout the country. But what are you going to pay for out-of-pocket healthcare costs? I don't know. It really depends on the plan. So that's why the range typically for Medicare Advantage is $0 to question mark. To help you get a sense of sample out-of-pocket costs on Medicare Advantage plans, we ran 2 zip codes, snapshots in Southern California and in Central Florida. So we took a look at the Medicare Advantage plan landscape in these areas. Here is what most people see when they take a look at this chart. They see $0 in monthly premiums. But I'm going to show you what I see and what most people should at least be aware of, the costs. So the plans in Southern California are very unique because you can wind up being an inpatient, having an inpatient hospital stay and pay nothing in a copay. So not only am I paying nothing in monthly premiums, I don't have to pay anything when I go into the hospital or when I visit the doctor. But please note, prior authorization, prior authorization, prior authorization, prior authorization. These plans have come to a point where if you want to see a doctor, you're going to have to call up an insurance company to make sure that they agree that you should be seeing the doctor. If they don't agree that you can see the doctor or see the specialist or go into the hospital, you're on your own. So these are the things that I definitely want people to be aware of, because $0 does not mean $0 out of pocket. And please note the bottom box. The patient, let me blow it up for you. The patient is required to pay 100% of services not receiving prior authorization when required or not in network. These amounts do not apply to the out-of-pocket spending limit. According to the New England Journal of Medicine, surprisingly little is known about how much Medicare Advantage enrollees pay out of pocket for the services they receive overall across plans according to health condition or in comparison to beneficiaries in traditional Medicare. They just don't track spending when it's not covered by the plan or not getting prior authorization. We just don't know. So, all right, here's why the initial path determination is so important to be aware of when you are making it. So too many people make the decision thinking that they can always change later on. But as soon as you choose your Medicare path in 46 states, you basically have to imagine that an earthquake happens behind you. Now, if you want to change paths, types of coverage, you have to wait for a bridge. Bridges only show up at certain times of the year, and in order to cross, you have to follow the rules of the bridge. It's actually pretty simple to switch from original to Advantage. As long as you're doing it at the correct time of year, Advantage plans have to take you regardless of pre-existing medical conditions. Here comes the problem. People think I can switch from Advantage to original Medicare and get everything that's over there. No. Chances are you don't have your guaranteed issue right to get a Medigap policy any longer. If you don't have that guaranteed issue right, the insurance companies that provide that coverage can ask you about your health. If they find anything they don't like, they can deny you that coverage. So if you were to switch to Advantage to original Medicare but do not qualify for a Medigap policy any longer, let's be honest, switching to original Medicare is like fiscal suicide because of all of the out-of-pocket costs inherent in Part A and B by itself with no out-of-pocket spending limit. So this is why we say people can essentially wind up getting stuck because of the out-of-pocket costs. Yes, I forgot that I programmed that in there. So now, step 6. Let's talk about the other side of the equation over on the other end, reviewing your coverage annually. Each year, Part D drug plans and Medicare Advantage plans, not supplements, Part D drug plans and Medicare Advantage plans essentially change how they work. As a result, it is really, really important that clients just don't put Medicare on autopilot. So October 15th through December 7th is a key period for anybody enrolled in Medicare. If you make plan changes, those new plans will take effect January 1st. And again, you want to check Part D drug plans and Medicare Advantage plans for any changes in premiums, deductibles, out-of-pocket costs, spending limits, coverage limitations, prior authorization, provider and pharmacy networks, medications that are covered, not covered. It can make thousands of dollars of difference. Dorella is a case study for us. Dorella believed, like a lot of people, those insurance companies are going to get your money no matter what you do. Why would you involve yourself in the pain of trying to figure out which plan's best for you? She was shocked to learn that changing drug plans for 1 year saved her $21,000. Our two record holders for the 2019 open enrollment period were two people who both saved more than $70,000. So just a couple more points if you'll hang in there with me just a little bit longer. I know this is a lot of information to take in and it sometimes feels overwhelming, but really imagine how your clients feel. So anything else to know? Sure. Two quick myths. Medicare myth number 1. Everyone pays the same amount for Medicare. No, some people pay more for Medicare. It's called the Income-Related Monthly Adjustment Amount, IRMA. Oh, I missed the word monthly in there. In 2020, singles with incomes above $87,000 or couples with incomes above $174,000 will pay higher Medicare premiums. IRMA amounts are per individual. So if you're looking at a couple and both of the spouses are on Medicare, take that IRMA amount and double it because they're both going to be paying it. Social Security generally uses a person's tax returns from 2 years ago to determine the current year's IRMA premium. With a life-changing event, so let's say the client is now retired, so that 2-year look back is significantly higher than the income the person will produce this year because they don't work anymore. Life-changing event notices are really key to helping people get those premiums reduced downwards. If they don't file those life-changing event forms, they're basically flushing money down the toilet. So this is just a chart of single filers and individuals filing jointly. There's also a chart for married but filing separately. And it just gives you a sense of the type of premiums that a person can be paying. And it can get pretty hefty. If your clients are in the upper tiers, you're looking at $400 a month per person. So please know that one-time income transactions can activate IRMA. So if your client has lottery or casino winnings, how they take capital gains, sale of property, Roth conversions, these are all things that can trigger IRMA unnecessarily. The income will affect premiums for 1 year only. So, I mean, the good news is at least if they do this accidentally and didn't take it into account IRMA when making those Roth conversions, it will only impact their IRMA premiums for 1 year. All right, last but definitely not least, Medicare covers long-term care. No, nope, nope, nope. 56% of baby boomers still believe that Medicare will cover their ongoing long-term care needs. They will come into your office and say, I have a long-term care plan, it's Medicare. Oh boy. And 45% of boomers believe they will actually need long-term care at some point. Let's take a look at the actual reality. Medicare pays nothing for long-term care needs, ongoing long-term care needs. And more than 70% of baby boomers will need care at some point. So you put these two myths together, we've got massive whammies going off in this country. And I get the phone calls very often from spouses, from children who think, well, how do I get Medicare to pay for the care that my dad needs now, that my wife needs now? It's not going to happen. So, and those costs can add up. So nursing home, national average $82,000 a year. Assisted living facility, $43,000 a year. Ouch. Please help your clients plan for this ahead of time. Final tips. Medicare has a deadline. Most retirement planning conversations do not. Please use the Medicare conversation as a jumping off point for these other conversations, and don't assume somebody else is helping your clients with Medicare. It's a very confusing, complex landscape with not a lot of resources helping, truly helping your clients. And remember, just one mistake can cost a client thousands of dollars a year, even hundreds of thousands of dollars. But you can help your client, because anything you do can help, at least if nothing else, open their eyes. We do have a solution that empowers professionals to help clients without becoming a Medicare expert. If you want to learn more about that, you absolutely can, but the point of this was educational, not sales. So I'm going to dive into the questions right now. Let me see, there is a Q&A box, so if you have anything that you need answered, let me know. When is COBRA considered viable coverage? COBRA is always secondary to Medicare, so you can have COBRA coverage, but it's secondary to Medicare when the client is over the age of 65. How do you convince clients to do an annual review, or other people who aren't clients but think, okay, because we did that years ago, we're all taken care of? Honestly, tell them the case studies. You can go to our website, 65 Incorporated, to pick up these case studies. We have an infographic on the 65 Incorporated website that has statistics about the average amount that people overpay per year that they haven't reviewed coverage. It's like $368 per year that they haven't reviewed coverage. So if your client hasn't reviewed in 5 years, 368 times 5. I have a client who works for a very large company. I'm actually going to skip specific case studies because there's ramifications I can't get into when diagnosing specific situations. I'll try to round around with people afterwards about specific situations. How do you advise clients looking at either Plan N or Plan G for 2020? Well, it really depends on their unique benefits and their unique health, financial, and lifestyle needs, and really taking a look at the differences between Plan N and Plan G, and then simply enlightening the clients about what the differences are, what might the costs be, and then taking a look at the premium differences. Does the difference in benefits really justify the differences in the premium? So that's how we do it. A guaranteed issue state in Washington, I'd take a look at that because it's guaranteed issue for people who already have a Medigap policy, not for people switching from Medicare Advantage to Medigap. You can switch Medigaps if you already have a Medigap, but switching from Medicare Advantage to Medigap, not so much. Does an MAPD client who moves out of their MA plan coverage area get a second chance at Medigap with no underwriting? Thank you, Joseph, for this question. We call this the nuclear button. What this means is basically if your client, if the wheels fall off and Medicare Advantage is not working for that client, the nuclear button is moving, but a serious move, not just like down the street, not just, 2 zip codes away, like moving. Because, and not just for a month, not just for summer months, you have to show, this is not something you want to play with. So insurance fraud gets into the works, and federal fraud, you don't want to play with it. So if you are serious about, getting a Medicare do-over, move, and make it a real move. How do you get around hospital observation status rather than being admitted? If you are on observation status, you have to ask the hospital to admit you. If you don't have full admittance status, you don't have full admittance status. There's really no way around it if you are not, if you have the wrong classification. So I understand that California also has an open enrollment period that is in the person's birth month, correct? California has something called the birthday rule. This is for people already enrolled in a Medigap policy. It is a 61-day period, their birth month, 1 month before, 1 month after. They can get a Medigap policy that is as good or less good than the current Medigap policy they currently have with no underwriting. So it does not qualify for people, again, moving from Medicare Advantage to original with a Medigap. Is there a tool to compare original Medicare plus Medigap to Medicare Advantage? That would be I-65. but again, I'm trying not to do sales here, Dawn. But other than that, government tools, no. No, it's really self-study. A good insurance agent can also potentially help you do this, but make sure it's a good insurance agent. A Medicare Advantage only insurance agent will not do this comparison for you. If a person has creditable coverage but did not enroll during the 7-month initial enrollment period, are they okay? Okay, well I would have to know a little bit more about that situation in order to give you specifics. I apologize because there's a few questions that I would have to ask you in order to give you that answer. What is the process to get IRMA increased premiums reduced when the income drops? So it's filing a life-changing event notice. I-65 has an IRMA calculator and a link to the form, but it's the SSA 4 form, SSA 44 4s. It's SSA 44 or SSA 4. And that's the form that you fill out. The specific process is really following the form. That specific situation is really the late enrolling for Medicare Part A, and since the guy never got enrolled, okay. Does final analysis, okay, so for filing IRMA exemption, does the final analysis get done after the actual tax return for the year is filed? No. No, if you wait that long, you might be too late. You can use the anticipated income. And the reason that you can do that, they are required by law to take your client's word for it because, quite frankly, they can double check your tax returns next year. And if you lie, they can ding you for it. So you have to prove, there are certain rules that you have to follow when proving that there's no longer, there's retirement, no longer active employment. But when it comes to income, you can use anticipated income. Let's see. Let's see. All right. What are the best tools to help gauge future Medigap? The best tools to help, and I'm not sure if you mean predicting premiums. There's there's 3 ways Medigap policies are priced: attained age, issue aged, and community rated. Attained age rated go up every year a person attains a new age. Issue age is based upon when the policy was issued to the client, and community rated is based on the health of a community. Community rated policies have been shown to be the most cost effective over a lifetime. Attained age rated have been shown to be the most costly into the 80s and 90s. Simply knowing that can help a lot, but best tools and resources, I-65. The future Medigap. That's a really tough question, and I'll try to figure out a better answer. I'm sorry it wasn't as good. I think best way to gauge possible Medigap premiums into the future. Okay, so I did answer the question. Awesome. That is the end of the questions, and I don't want to keep you any longer. I will process CEs. I will put up a recording. Thank you so much for joining me today. And if you have any questions or concerns, please reach out to me. Otherwise, thank you so much for joining us.